All right, we're just going to wait a little bit longer and let everyone get logged in, and then we'll start with our presentation. All right, we have a couple more coming in. We're just going to wait 1 more minute, and then we'll get started. All right, let's get started. And if more people come in, they can always watch it later anyway. So hi, everyone, and thank you for attending Envia Fertility's Patient Education webinar on PCOS. My name is Vicki, and I'll be your moderator for this informational session. I'm honored to present to you the speaker of our webinar, Dr. Elizabeth Puscheck. Dr. Puscheck trained at the Washington University Medical School in St. Louis and then completed her fellowship at the Medical College of Georgia. She has specialty interest in ultrasound and takes care of the full range of infertility patients. I look forward to her presentation today. So now that you know a little bit about us, we want to know just a little bit about you. I'm going to put a poll up on the screen.
We're not seeing the poll yet.
Hang on. Okay, so if you could just answer this question, we'll give you a few seconds to do that, and then we'll share the results with you. All right, just a couple more seconds. All right, we're going to close the poll and share the results. So we can kind of see we have a good group. I'm glad to see we do have one of our patients listening to the webinar. But this will also help Dr. Puscheck to be able to tailor to our group. So I'm going to stop sharing the results. We'll have other polls during the presentation, and it would be, we'd be grateful if you could share your responses with us. If you have any questions, please type them in the Q&A box, not in the chat box, because we're going to keep our eye on that one, and that's where we're going to pull the questions for at the end. Now I'd like to turn this over to Dr. Puscheck to share with us her presentation on getting pregnant with PCOS.
Well, good afternoon. I'm delighted to present Getting Pregnant with PCOS. It's a topic that's near and dear to my heart. Next slide. There you go. So here you can see all 3 physicians at Envia Fertility, myself, Dr. Klibstein, Dr. Crondy, and you heard my bio already. So we all work together, and I'm going to tell you a little bit about our favorite topic, PCOS. Next slide. We have 4 locations at Envia Fertility: Hoffman Estates, Arlington Heights, Northbrook, and Crystal Lake. You can look us up on the website. You can call us and make an appointment. You can make an appointment on the website as well. So let's go on with the next slide. And keep in mind that you can type questions at any time in our Q&A box, and we'll address them at the end of the presentation. So don't be afraid to ask any question. There's no silly questions. We're here for you, and whatever we can help you with regarding PCOS and infertility, let us know. Next. So what is polycystic ovary syndrome? We're going to delve into that over this talk, and we're going to look at some of the possible treatments. Let's go on with talking about what PCOS is first. So some of the facts on the left side talk about that PCOS is really one of the most common endocrine disorders of reproductive age women, Women who have ovulatory disorders, about 80% of them have PCOS, so it's very common. They may present with a menstrual disorder, irregular cycles, infertility, or hirsutism, and I'll get into that definition in a little bit. It's basically male patterned hair growth. And a lot of PCOS patients have trouble with obesity, about 70%, but it's not required for that diagnosis. One of the key things for PCOS is that it is a lifetime disorder, and women with PCOS are at increased risk for insulin resistance, type 2 diabetes, lipid abnormalities like high cholesterol, increased heart disease, and early onset and increased risk for uterine cancer. So if you get this diagnosis, certainly you want to make sure that you have regular follow-up. And there are different things that we can do to reduce some of these lifetime risks, and we're going to talk about that today as well. Next slide. So making that diagnosis of PCOS, it's not as easy as making a diagnosis of, say, thyroid disease or diabetes. There's no single test that makes that diagnosis. In addition, there have been a number of different societies that have been arguing over what tests are important to make the diagnosis. So there's different criteria that are used to make the diagnosis of PCOS. The most common one in use right now is the Rotterdam criteria. And again, it's different than your thyroid disease or diabetes in that it's not relying just on a laboratory test. We look at a whole compilation of symptoms, signs, and laboratory tests. And for this diagnosis, you need 2 out of the 3 of the following things under the green check mark. So ovulatory disorder, androgen excess disorder, or PCO appearing ovaries. Now I'm going to go through each of these criteria with you, and we also need to make sure that we rule out any other disorders that might look like PCOS, like thyroid disease or some adrenal problems. Next slide. So PCOS can be represented by this overlapping Venn diagram. So you see these 3 circles, and the area that is in red and black are the people that would have PCOS. So you can have an ovulatory disorder and an androgen excess problem, and that would be PCOS. You can have androgen excess and a PCO appearing ovary, and that could be PCOS. You could have PCO appearing ovaries on ultrasound and an ovulatory disorder, and that could be PCOS. Or you could have all 3. So it's a very heterogeneous disorder. And in addition, it can be genetically complex. Next slide. A lot of people really ask me about, is PCOS hereditary or not? And we think it is hereditary, but it's not a single gene disorder like sickle cell or cystic fibrosis or something like that. It's actually most likely a combination of genes that contribute to different parts of that PCOS syndrome. And so these days we can do all kinds of genetic testing. I might lose you on this. It's called a genome-wide association study, where we're actually screening the whole genome and comparing certain genetic markers between those patients that do not have PCOS, which would be controls, and comparing these markers to people with PCOS. And so far in the literature, we found about 8 different markers in genes that are related to things that you wouldn't be surprised about. So insulin signaling and type 2 diabetes, reproductive hormones. So that would all make sense, but it's still very complex, and we're still learning more and more about it every day. So let's get back to making our diagnosis with an ovulatory disorder. This is one of those 3 circles we talked about. And if you look on the right-hand side of the screen, you'll see a calendar of the 12 months. And if you just track your periods, and this is where I put the red boxes of where this woman's periods were. You can see she had a period in January, but nothing in February. She had a period in March, and then no periods in April or May, but a long one in June. And if you look at August, she actually had 2 periods. So when we're thinking about irregular periods for PCOS, it can be any of these things. Periods that are more than 35 days apart from the beginning of one cycle to the beginning of another. An easier way to think about that is just missing entire months. But also periods that are too close together are usually another indicator of an irregular cycle that may be related to not ovulating. And then of course, no periods out for the whole year would be another indication of an ovulatory disorder. So these kinds of patterns indicate that a woman is either not ovulating or infrequently ovulating, and that would make our criteria for this particular circle. Again, we need 2 out of the 3. The next circle I'm going to talk about was the androgen excess. Now, androgen excess is illustrated in the images on the pictures to the right side of the screen. So hirsutism is that male pattern hair growth. So think about men, if they're having a beard being formed, hair that's in the upper lip, the chin, the sideburn area, the under the neck, the chest, the abdomen, the lower back. It's that dark, coarse hair. So it doesn't count to have that peach fuzz on your face or the lighter haired skin on your arms. That's not what we're talking about. It's the ones that are really the dark, coarse hair. In addition, androgen excess may be more of the acne, like we see in the woman on the top picture. There are certain ethnic differences where certain women are more prone to have hirsutism. Some of the Middle Eastern women have more hirsutism and may not have any laboratory abnormalities or a lower level androgen with the hirsutism. Others, like some of our Asian patients, Chinese patients, may have less hirsutism and have more elevated androgen. So all of this would be that spectrum of androgen excess. And our next slide is the PCO appearing ovary and ultrasound. So this is truly just an ultrasound diagnosis. And if you look on the left side of the screen, the lower image is a ovary. It's actually the right ovary. And then that screen right above it are actually 2 images. The top one is the uterus with a thick lining, consistent with an anovulatory lining, but we're going to focus on the one right below it, and that's another ovary. If you look at these ovaries, you can see little black spots, and those little black spots all in a line kind of remind me of a pearl necklace. So it's actually called a pearl necklace sign on ultrasound, and this is often associated with PCOS. So in looking at an ultrasound diagnosis, we don't have to have the pearl necklace sign, although that's very characteristic. We just need to count up these small follicles, and if there's 12 or more, either on one ovary or in the combination of the 2 ovaries, that would make the diagnosis for a PCO appearing ovary. Now, it is totally wrong to think of a PCO ovary as true cysts. I can tell you I've had several patients come to my office saying that they were told they have polycystic ovaries and they want the cysts removed so they can get pregnant. So these are not pathologic cysts. No surgery is required to remove these cysts. These are ovaries that have a lot of follicles in them. A follicle is a fluid-filled cyst, but it's not really a cyst because it's small, and those have eggs in them. So the problem is really the eggs aren't being released in this disorder. The best news, the great news, is that this disorder is associated with having lots of eggs. So if I were going to have an infertility problem, I'd like to have one with a lot of eggs. So this is a good sign. Next slide. So when we make the diagnosis of PCOS using this Rotterdam criteria, we just need 2 of those 3 circles overlapping. And we can make that diagnosis very easily within 2 visits, actually almost in 1 visit. If we weren't having COVID right now, we would have you come into the office for a consultation, do a history, a physical exam, and ultrasound all in the same visit, draw some blood for laboratory testing, and we'd already have a pretty good indication of whether or not you had PCOS, and just do a follow-up for the consult to review the results and discuss your diagnosis and what kind of treatments. And still now we can do it still in a couple of visits. It's a very common disorder, and surprisingly it goes undetected or missed in a lot of cases. And that's a real problem if you're trying to get pregnant. It's one of the easier diagnoses for us to make. And if you're not sure if you have PCOS and just want to find out, we're happy to see you and help you with that. And like everything in fertility, age matters. So an early intervention is really important. We want to be able to help you sooner as opposed to later. We're going to have another poll here. Do you think you have PCOS? We'll give you a minute to answer this. So we should be almost done here. How's it doing there, Vicki?
I'm just
We'll be
giving
seeing the answers
a second.
popping up here in a minute.
Yeah, hang on one second. It looks like most of the people have submitted their vote. So I'm going to end the poll and share the results.
Thank you. Okay, so about 40% of you think you may have PCOS, and about 40% aren't sure. So again, if you're not sure, come on in and we'll talk to you in our office and or by Zoom, and we'll help you make that diagnosis. Well, next, I would really like to talk about how PCOS and infertility go hand in hand, as well as talk about the pregnancy complications associated with PCOS. So infertility is diagnosed by not having a conception after 1 year of unprotected intercourse. So it doesn't say that you have to be ovulating or have to be actively trying. It's just 1 year of unprotected intercourse. And we see with PCOS patients, about 75% of all patients have infertility. About 50% of PCOS patients have primary infertility, meaning they've never been pregnant at all before. And 25% of patients might have gotten pregnant before and now having trouble with the next pregnancy. About 30% of women with PCOS do ovulate, so it is possible for you to conceive on your own. But if you're not ovulating regularly, you may not be timing the intercourse right, or we may need a little extra help, and we're here for you. Women with PCOS also have some particular pregnancy complications that can occur. The one I get worried about is a higher early miscarriage rate, and we'd like to help you get pregnant via fertility and then help you stay pregnant. But additionally, we worry about gestational diabetes, which is diabetes that's occurring only in pregnancy, or pregnancy-induced hypertension, which is high blood pressure happening in pregnancy, and preeclampsia is a similar disorder. Both of these are more common in PCOS patients. You can have babies that are smaller than they're supposed to be, and you can have a higher incidence of preterm birth. So certainly once we get you pregnant and we get you past that first trimester, we'll be sending you to your OBGYN with the alert that you'd be at higher risk for some of these disorders. Next slide. So what can I do to get pregnant? In the following slides, I'm going to talk to you about some of the easy treatments that you can do for yourself to help you conceive. And some of these things are really good at reducing your lifetime risks for some of those things we talked about earlier. One of the key points I'd really like to drive home is, although you may have PCOS, you have a good prognosis for getting pregnant. And so, this should be something that you're going to keep that in mind, because it's good to think of something positive. Okay, next slide. So what can I do to get pregnant? Certainly we want you to have a regular exercise routine. Exercise is always a healthy thing on a moderate basis, not a marathon or anything, but just moderate exercise. Walking's great. A dietary intervention, so eating healthy is important prior to getting pregnant, in anyone who's trying to get pregnant. But in women who have PCOS, weight loss, particularly if you're overweight or obese, can be very important. And we're not talking about getting down to your ideal body weight. We're just talking about losing maybe 5 to 10% of your body weight. So maybe, 10 pounds, 15 pounds, something like that. And it's really important because just losing that little bit of weight, which, a lot of my patients, when I talk about weight loss, get concerned that I'm going to ask them to lose a lot of weight, just, 10, 15 pounds is often enough weight loss to help your body re-signal and get the menstrual cycles coming more regularly. And some patients get pregnant with just a little bit of weight loss. In addition, losing 5% of your body weight has been shown to reduce your metabolic risk. So that risk for insulin resistance and diabetes and something called the metabolic syndrome is reduced if you can just lose that amount of weight. So that's a really good thing that you can try. Now, of course, weight loss, what works? It's difficult. It takes time and it takes a commitment, and which diet is the right diet? Certainly, people have tried studying a variety of different diets, both in people who have obesity problems as well as those with PCOS problems. And we often think of maybe a low carb and low carbohydrate and lean protein diet can be very helpful with PCOS patients. But I think it's really important to identify a diet that is healthy and that you can live with. Because if you can, it shouldn't be just, I'm going to do this fad diet, lose the weight, get pregnant, and then gain it all back. It needs to be a diet that you lose the weight and you just keep it off while you're trying to get pregnant. So that could be a Weight Watchers approach where you're losing weight and also have, and this is just reducing your caloric intake, which is about 90% of how people lose weight. But Weight Watchers gives you a little bit of a support system, which can be helpful, and it can be done online. At Envia Fertility, we offer a weight loss program, which is called the Ideal Protein Weight Loss Program. And again, it's something if you want to do, we offer it at a discounted rate for our patients. I found, I actually used that diet. I wanted to try it out if I was going to talk to my patients about it. And I was interested in losing maybe 10, 15 pounds. It was a diet that I found very easy to work with. It comes with a coach too. And I ended up losing 55 pounds. And I did that over maybe 4 or 5 months. So it went very quickly and it was very easy to live with. So again, with PCOS, you don't need to lose that much weight, just usually 5 to 10%. And there's a variety of ways of doing that, and we'd help you with that. Some of my patients ask me if they should use bariatric surgery. Well, one, there's no quick and easy way to lose weight, and bariatric surgery does have some risks. With patients that have PCOS, it's really a small number of those patients that would be candidates for this surgery. It's really reserved for those that are morbidly obese or have obesity with other comorbidities like diabetes or something like that. Or if people have failed a number of dietary approaches, then it may be indicated. A bariatric surgery these days is done by a minimally invasive approach, and usually we're shrinking the stomach size for the most part, so a sleeve or something like that is often used. The problem with this is that when you do this kind of surgery, you're losing weight very rapidly after the surgery, and you need about a year for your body to lose the entire amount of weight and then adapt to these changes prior to conceiving, so it's safe to conceive. A number of patients who have chosen this route have come back to me and said they've already started ovulating. 53% of these patients do ovulate on their own. And I've had patients come back already having conceived. So certainly for some individuals, it can be helpful, but most PCOS patients don't need to use bariatric surgery. Next. So now I think it's time to see a specialist. It's an easy appointment to make. The initial appointment is just a consultation. Now we're doing it by telemedicine. And why a subspecialist? Well, we at Envia Fertility are all OBGYNs with a subspecialty training and a fellowship called Reproductive Endocrine and Infertility, and it really focuses on infertility. So why Envia Fertility? Well, this is our expertise. This is what we do every day. We have a team dedicated to help you, and we individualize our treatment based on your history and your needs. Not all PCO patients are the same. As we show, there's a very heterogeneous population, and each PCOS patient may need a different treatment. All of the physicians at Envia Fertility are board certified, and board certified in our subspecialty. Next slide. So when we're talking about infertility, it is a couples disorder, and so it is male and female, but I'm going to focus just on the female factors for right now. If you look at this pie chart, a bulk of female factors are due to ovulatory disorders, a little more than a third. Other things that may be considered are tubal factors, which may be blocked or diseased. Diminished ovarian reserve is where the ovary doesn't have as many eggs. And then uterine factors are endometriosis and some combinations of factors. Age increases the risk for infertility. So again, seeing a physician in our subspecialty sooner for infertility is a better idea for someone with PCOS. Next slide. So in the infertility evaluation, I'm going to go over that just as a brief overview. We have another webinar that's going to be talking about Fertility 101, and we'll delve into this evaluation in more depth. And then here's a couple of hints for optimizing PCOS. So doing a complete infertility evaluation is important because women with PCOS do have about a 20 to 25% chance of having more than one problem with trying to get pregnant. So we like to do a quick overview of the different tests. So a semen analysis would be our evaluation of the male along with his history, a uterine cavity evaluation along with testing for tubal patency, and laboratory tests looking at your hormones and ovarian reserve. Again, PCOS patients often have a very good ovarian reserve. And as I mentioned, 20% will have more than one diagnosis. We'll also check you to see if you're at risk for diabetes or prediabetes with a couple of blood tests like the hemoglobin A1C and a 2-hour glucose challenge test. And then those individuals that are at higher risk, we may want to treat with metformin. And it's important. So some patients who might have had metformin before, oftentimes it's not given in a way that is easily tolerated. And we'll often take a low and slow approach and get up to a higher dose than what a lot of patients are treated with, because a lot of PCO patients need a higher dose of metformin to combat that insulin resistance. Hypertension, we'll want to make sure that you get on pregnancy-friendly medications prior to starting, and then we'll assess other issues to optimize your health. And then we're ready to look at all these results and talk about your next steps. Next slide. So treatments may include things like lifestyle changes like we talked about, oral ovulatory agents, gonadotropin therapies, which are injections, and IVF. I'm just going to give you a brief overview of these treatments, and we'll go over this in our Fertility 101 webinar for types of treatments. So Clomiphene citrate is an oral agent. It can be given for 5 days out of the month. A lot of people call it Clomid. And the idea here is to get 1 to 5 mature follicles to ovulate. And the side effects happen about 10 to 15% of women, which might be hot flashes, mood changes, and occasional cysts. But again, it's usually one that goes away, not something that needs to be operated on. And the more worrisome thing is the multiple rate. It has a 3 to 8% chance for twins, and then less for triplets, etc. There are still some patients with PCOS that don't ovulate despite an increasing dose of Clomid. And so we'll talk about that as well, the next steps on that. And Clomid is a very low-cost medication and doesn't require a lot of monitoring. Next slide. So it doesn't matter if you lose weight first or start the fertility treatment first. But let's look at some of the data for this. Next slide. There are 2 studies that have been looked at after the fact to determine, if we can have some weight loss and have that help people who have PCOS. So the first one is OWL PCOS study. It's a randomized controlled trial that was open label, and I was actually involved with both of these studies. And we divided all the PCO patients into 3 groups, one that were pre-treated with a birth control pill or oral contraceptive for about 4 months, one that pre-treated with lifestyle changes only, and one that had a combination of birth control pills and lifestyle changes. The idea here is that some people thought that if you started with a birth control pill and then stopped it, your PCOS patients might do better. And so after these 3 different treatments, they all got up to 4 Clomid cycles. The other portion of the study that we're comparing it to was a PCOS 2 trial, which is also a randomized blinded trial between 2 different oral agents, and I'll get to Letrozole in a minute, but we just took out as a post-hoc analysis just those that were taking Clomid. So these patients had no pre-treatment. They went direct to up to 4 cycles of Clomid, and so they didn't do any weight loss or anything like that. And then we'll show the data in comparison. Next slide. So for both of these studies, they both use the same diagnostic criteria for making the diagnosis of PCOS. For those that did the weight loss, they lost on average about 6%. Remember, I mentioned 5 to 10% is what we're looking for, and they did that prior to using Clomid, versus those that went to direct to Clomid and all had up to 4 cycles to get pregnant. In the chart below, we are showing on the top row the category of either no weight loss and going direct to Clomid, or weight loss first and then Clomid, and then there's something called a p-value. And if it's less than 0.05, it's considered statistically significant. So in this situation, we see that although the ovulation rate was 45 to 62%, it was higher in those that had weight loss first. The clinical pregnancy rate was higher in those that did weight loss first and then Clomid, and the live birth rate was higher if you lost the weight first. The miscarriage rate, although it does look like it's lower if you lost the weight first, the numbers that actually miscarried were too low to actually be statistically significant. So that jury is still out on that one. So it looks like weight loss was better if we did that first before using Clomid. Next slide. So other considerations besides weight loss, well, of course, if a woman's 37 or older, we don't want to wait. Age is really important. And I get it, optimizing the health is also important. So how do I deal with balancing these two things? Well, my solution is let's try losing that 5 to 10% body weight over the couple months that we're first doing that initial evaluation, which might take a couple of weeks to a month to get the evaluation and the insurance authorization, and then continue to using an approved weight loss program until you're pregnant. That often, I think, works the best as a compromise between the two. Of course, you can proceed direct to treatment as well. So different PCOS patients, we might adjust that differently, but depending on where you're starting with your weight. Next slide. What other choices do I have for PCOS treatment? So I also mentioned, next slide, the other medication called Letrozole. This is also an oral medication. Some people know it by Femara, the brand name. It's also given for 5 days out of the month, but it works by a different mechanism than Clomid does. Here we're only likely to get one follicle to ovulate, but if you're not ovulating regularly, getting one follicle to ovulate can be helpful. The side effects seem to be less with Letrozole. The multiple rate is still about the same, about 8%. It is also a low-cost, low-tech approach, but it's slightly more expensive than Clomid. And interestingly, about half of those who did not respond to Clomid can ovulate with Letrozole, so it is a nice alternative. Letrozole is not FDA approved for this treatment, and it is legal, it is allowed to use an FDA off-label medication for something like PCOS. It's commonly done. This is a study that just showed a lot of physicians that were polled to see if they were using medications off-label. And of course, it's up to the physician to understand the medication and its side effects prior to prescribing, and it's done all the time with PCOS patients. So next slide. So one of the things that came up with Letrozole was a worry about birth defects. And I brought this up because a lot of patients worry about it. The presentation was initially showing in 2005 about 150 babies that all were exposed to Letrozole when their moms were getting pregnant, and some of them had cardiac or movement disorders. This was never published. It was only presented at a national meeting. So that means it didn't make it through that full peer review process. So we don't know how good that study was. There was a follow-up paper out of Canada in 2006 that refuted that risk for birth defects. They looked at over 900 babies after Letrozole. They also looked at babies after Clomid, looking to see if there were birth defects, and there was no increase in birth defects. The background rate for birth defects for anybody who gets pregnant is about 3 to 4%, and that didn't change for either of these medications, so they're fairly safe. Next slide. What about how Letrozole and Clomid compare? Which would be better for me with PCOS? Well, there was a nice study on this, and next slide. It was published in the New England Journal of Medicine, and I was involved in the clinical trial for this as well. And we found that Letrozole performed better than Clomid. And again, I made a table similar to the one we just looked at. And next, you can see in the yellow boxes that the ovulation rate, the conception rate, and the live birth rate were all better with Letrozole. And we had about 375 patients in each arm. The twin rate was pretty similar, even though it looked like it was a trending low on the Letrozole. And the miscarriage rate was the same. So those two were not statistically significant. So when we have PCO patients that we're looking to do oral treatment with, we'll often pick Letrozole as our first line. Next slide. And I jumped the gun on that one. Letrozole is our first line treatment for PCOS patients who need an oral agent. Next slide. So common questions, how long should I use these oral agents? What happened if I don't conceive, and what's next? Well, certainly these oral treatments, we don't want you using them for a long time. Usually most patients are going to have conceived within the first 3 to 4 cycles of using an oral agent. Some patients want, if they're younger, and we'll look at each person individually. Some patients may need up to 6 cycles on oral treatments before moving on, and others will move a little quicker depending on what their problems are. Next slide. So gonadotropins is what I mentioned as another treatment that's available. It's often used for patients who have failed oral treatments either because they didn't ovulate or they didn't conceive, and over 90% of PCOS patients do ovulate with gonadotropins. The problem with this, and I have more on this slide than we actually need, is that it's much more involved. It's an injectable therapy using the same hormones that your body would normally be making, but we use it in higher doses so we can get those follicles to grow beyond those small little follicles to bigger follicles, and then we can get them to ovulate with a trigger shot. The side effects are usually pretty well tolerated, but the one I want to focus on is the high risk for multiples. Next slide. So here you can see sextuplets. This is not what we want to see. When we're using gonadotropin therapy, particularly for a PCOS patient, it's an uncontrolled risk for these multiples, particularly what we call high order multiples. Higher order multiples are those that are more than twins. And this is not the situation you want to be in. When patients are pregnant with more than one baby, and particularly more than twins, there's more risk to the mom and there's a lot more risk to the baby. So we want to avoid this treatment, particularly in PCOS patients, because again, we can't control for that. So instead, what we'll often move to next is IVF. And IVF and PCOS is an excellent treatment because remember, you have a good number of eggs. Now, most of our PCOS patients can get away with the lower tech treatments that I've already mentioned. But if you happen to need IVF, this is a good treatment. It still does use the gonadotropin therapy and injectable medications, as I mentioned. We monitor you very closely. We individualize your dosing so we can adjust it as we go. And we add another medication to block ovulation so that we can push things a little bit further and retrieve more eggs. You'll still need to have a trigger shot. And then we do a minor surgical procedure to remove the eggs in the office. It's basically a needle procedure under ultrasound. It's not a difficult procedure for you to endure, and you do have anesthesia, so you feel pretty good during the procedure. At the end of the procedure, you'll find out how many eggs we have, and we'll inseminate the eggs the same day. The next day, you'll find out how many embryos were formed, and we'll grow them in culture. And we'll transfer just one embryo so that you'll have a great pregnancy rate. Usually there's excellent pregnancy rates for PCOS patients in the 50 to 70% range, and we can freeze the rest of the embryos. By transferring one embryo, we reduce that risk of multiples considerably. It's under 2% chance of getting multiples then. Next slide. The additional advantages of IVF in PCOS patients, again, you have an excellent prognosis. You typically get more eggs from a PCOS patient than other infertile women. And we learn about your egg quality. How many of them were mature eggs? How many were immature? And again, we learn about that quality. PCOS patients have high pregnancy rates on that 50 to 70% range. And remember, you can freeze the remaining embryos so we can help you with your next pregnancy without having to use all the gonadotropins and all the monitoring. We can help you very easily with much less involvement. The frozen embryos have similar high pregnancy rates for PCOS patients. And you can keep those frozen embryos for as long as you want to. My personal best has been 13 years. Now, most of you want to try and get pregnant with your next pregnancy with maybe in a couple of years and not wait that long. But it certainly is possible to wait as long as you want to. And that picture on the right is a picture of a nice first trimester pregnancy. Next slide. So at Envia Fertility, we do report our pregnancy rates to the CDC as federally required. And this is a table showing our new patients. So this is all patients coming to see us in Envia Fertility. And what is their live birth rate as a new patient? And you can see here on this chart that if you focus on next, the live birth rate, which is really the most important part, is very high for new patients coming to Envia Fertility. So 68% in less than 35-year-olds, 62% in 35 to 37-year-olds, and then those under 40 still have a 41% chance. So you can see as you get older, it does reduce your risk to get pregnant, but these are high pregnancy rates. Next. So getting pregnant with PCOS, it's really my favorite patients because you have excellent success rates with getting pregnant. It's an easy diagnosis for us to make. We see it all the time, and we can help you make that diagnosis. And the better news is that most of our PCOS patients respond to low-tech treatments and lifestyle modifications, so you don't have to go to the IVF procedures. And we at Envia Fertility are here to help you make the diagnosis and help you get pregnant with one healthy baby at a time. And that's my favorite motto. Let's get pregnant with one healthy baby at a time. So next. So I want to thank you for listening to my presentation, and I'm eager to hear what questions you have. You can reach us through that phone number there for Envia Fertility to make an appointment, or go to our website. So Vicki, what did you find for us?
So we had some questions submitted with registration, and we're going to kind of go over those first while we look at the ones coming through on Facebook and Q&A section. So the first one is, can PCOS be inherited from my parents, and can I pass it on to my daughters?
I think that's a very good question. It is very complicated. So certainly there are some features that we think are inherited, and it is very possible that you got PCOS from your mom. Just talk to your mom and ask her if she had that ovulatory irregular cycles, some of that hair growth. She probably won't know if she had a PCO appearing ovary, but it's very possible that you did inherit it from your mom, and it is also possible that you could pass it on to your daughter. It's just not so clear cut. I can't tell you, like in Mendelian genetics, that okay, you carry this gene and we match it with your husband's gene, and so we have, you know, a 25% chance. It's not quite that clear cut to say you have a 25% or 50% or 1%, but it does look like it runs in families.
Okay, the next one is, can I be cured of PCOS?
Well, that's a very good question. So we think of PCOS more as a lifetime disease, but we do certainly see patients who've lost some weight and then start ovulating more regularly. We have individuals that have had more regular cycles and then became irregular later as well. So it's a little bit where the jury is still out on that. We, for the most part, I think the majority of our PCOS patients do have the disorder as a lifetime disorder, and I'd like to make sure that you do follow up regularly, so you make sure that you don't have the diabetes or the high blood pressure or any of the other risk factors. But if you're losing some of this weight and you find your periods are getting more regular, maybe it is getting better for you.
Okay, another one is, does age increase my chances of having PCOS?
So it's probably the other way around, that PCOS is usually diagnosed early on. So oftentimes when women are first going through puberty, we'll have irregular cycles for a couple of years, but with PCOS, it may last a lot longer. And that's when we're making the diagnosis, is usually in the teens and early 20s. But there are people who have missed the diagnosis of PCOS, or maybe they have more of those androgen symptoms and signs and the PCO appearing ovary that they wouldn't know about, and they're seeing somebody who isn't picking up that disorder. So I've made the diagnosis later in life, but if you go through the history, you often find out that the symptoms were expressed earlier in life and it just wasn't picked up or diagnosed earlier. So I hope that answers your question.
I think so. You had mentioned in a couple of your slides that PCOS usually has a good number of eggs. Are they usually of good quality too, or is that something you can't tell unless you do IVF?
Right, so again, great question. You're coming up with lots of great questions. So yes, PCOS patients tend to have a lot of eggs. And when we get a lot of eggs, we know that some are going to be mature and some of them are not going to be mature. It's usually when we look at those eggs that we can see the quality of the eggs. So we do need that IVF piece to know what the quality is. But you don't necessarily need to have the IVF to determine your quality. If we're just getting you to ovulate a couple of 1 or 2 eggs and you get pregnant, it doesn't really matter, right? So you got what you're looking for to get pregnant and having a healthy baby to go home with. And that's really what this is all about. If you have all those extra eggs and some are immature or not as good a quality, then we may change that protocol that we're using to try and get you a better quality egg. And we can work with you on that too.
Okay. Another one is, does weight gain cause PCOS, or is it a condition that I would have had anyway?
So with PCOS, it's something that you would have had anyway. There are certain features of obesity that can be overlapping with PCOS, so it can get mixed. But as we saw, the diagnosis for PCOS does not have anything to do with obesity. So 70% of PCOS patients do have obesity, but it's not part of that diagnostic criteria. So you could be thin and still have PCOS. You could be thin, not ovulate, or thin and have a PCOS appearing ovary. You could have androgen excess. And so the weight part of it doesn't factor into our diagnosis for PCOS.
Okay. Does PCOS impact pregnancy after conceiving, or does it just make getting pregnant difficult?
Well, PCOS can make getting pregnant more difficult. And there are those risk factors that I've mentioned regarding pregnancy complications. So at higher risk for diabetes or high blood pressure, that is gestation specific, so pregnancy related. And those individuals that get diabetes, gestational diabetes, meaning only during the pregnancy, and then it goes away, are a little higher risk of getting diabetes later in life too. Same with the blood pressure, but PCOS patients in general are at higher risk for these things.
Another good question, are there any natural remedies for treating PCOS?
So I guess what you're talking about, natural remedies, we talked about the weight loss and exercise that can be helpful. I did not get into things like herbal therapies or acupuncture. We often do offer acupuncture to patients who are trying to get pregnant, but it's not necessarily PCO related. The herbal therapies, when they've been studied, haven't been shown to be helpful for PCOS. So that does not seem to be a good one.
Okay. Is there a diet that you recommend for PCOS prior to getting pregnant?
But again, I think it's a diet that you can live with. So I do like to emphasize the healthy diet. So eating fresh vegetables and fresh fruits and, leaner meats and trying to avoid those things with lots of salt and avoid frying things, of course. And staying more to baked items. So just thinking of what's healthy and what you like to eat and does that make sense? Now with PCOS patients, and I think a lot of patients are losing weight, the first thing is that caloric restriction. It's hard to do that. I think the carbohydrates make us hungrier sooner and want us to eat more. So going into eating, you could eat a lot more vegetables and get fuller on vegetables and not have had as many calories or carbohydrates and still stay full longer. But it's the protein that you're going to need too to help satiate you. So those are some suggestions, but I'm happy to talk to you about it further. We do have a coach with our dietary program. Weight Watchers is wonderful. And there are a number of other diets that are certainly available for patients. And we can talk about those at a visit as well.
How important are diet and exercise for PCOS and getting pregnant?
Well, again, if somebody is a little bit overweight, it can be very helpful. And somebody who is not overweight, so 30% of PCOS patients are not overweight. Certainly regular exercise, I think, is a good stress reliever. I think a lot of patients who have PCO or infertility, those are stressful life factors, and exercise is a great way to help alleviate stress, and so that can be helpful in those situations. And then other people find different ways to reduce stress, and whether you find meditation or yoga or other things that help you reduce stress, that can also be helpful.
Okay, we had a question come in from an attendee asking if hirsutism can go away. So I'm going to add on to that, asking, can acne also be something that goes away?
Mm-hmm. So basically, the hirsutism and acne are related to the androgens. And so if we are doing something that is reducing the androgens, like reducing your insulin resistance, then it can go away. Women on birth control pills usually are making less androgens because we've shut down the ovaries and actually a little bit of the adrenals. And so in those situations, the acne will get better. The hair growth that's already there typically does not go away and has to be removed, usually by a physical method, whether you're shaving or plucking or using laser or something like that. But it can slow down the growth so you don't get new hair growth as much. So that would be a better approach. But of course, if you're on birth control pills, it's hard to get pregnant. So
Right.
there's a combination problem there. I mean, we can use anti-androgens too that can help reduce that risk. But again, we don't want to use an anti-androgen when we're trying to get somebody pregnant, because that would not be a good thing for the babies to be exposed to.
Okay. This one came in. I've heard ovarian drilling can help with PCOS. Sounds scary, but can you tell me what it is and what it does?
Okay, certainly. So when PCOS was, or polycystic ovary was first diagnosed, it was during a surgery where they took a little wedge out of the ovary, and they found that women who had this wedge removed started to ovulate more regularly. Now, we don't do that kind of really invasive surgery anymore, but as an alternative, people have talked about ovarian drilling. And ovarian drilling is a laparoscopic, minimally invasive surgery where we basically make little, burn little holes into the ovary. We can do it with a laser, you can do it with electrocautery. And when you're doing that, the idea is to damage some of the stroma. Well, I don't think you actually get to the stroma, but it may actually be making little dents in the capsule so that the eggs can be ovulate and release. And we do see that patients do ovulate, usually one egg at a time, if they respond to drilling. And it is one of the treatments that is available for PCOS patients. It just hasn't been studied nearly as well in these kind of randomized controlled trials. And so it doesn't have as much data out there about how good is doing this ovarian drilling versus some of these other treatments that I've talked about. So it is one of the armamentarium of treatments, but it's going to be more invasive. And how long does that kind of treatment last for? Does it only last for a month or two and you have to do it again? Does it last longer? We don't have any data on that. So it's something that could be a problem.
Okay.
And so I like to talk about it with patients that want to know about it, but I don't think it's something that a lot of my patients end up choosing to do because there are other things that work better.
Okay. And how does hypothyroidism compare or contrast to PCOS?
Oh, that's a really good question. So with hypothyroidism, that's one of the diseases that we want to rule out to make sure that that's not what's causing the PCOS-like symptoms. And hypothyroid patients often don't ovulate. So, and your metabolic rate is usually slower, so you may have gained some weight, and that's not uncommon. Making the diagnosis of hypothyroidism is not difficult. It's a blood test, and we look at the TSH level. If it's above a certain amount, then we'll want to treat you with a thyroid hormone, which is a pill that can be taken. It's a very slow-acting pill. It has very minimal side effects. And then we can retest you in a month to 6 weeks later and see if you've responded to that. If you have, then usually the metabolic rate goes up. You might find that losing weight's a little easier. You might find that now you're starting to ovulate a little bit more, and if we find all these things out, then you didn't have PCO, you had hypothyroidism. So that's why it's so important to rule out hypothyroidism, and hypothyroidism is very prevalent in women. It's much more common in women than in men, and again, very easy to treat. So you want to make sure that we haven't missed that diagnosis because we would treat that very differently than we would PCOS.
Okay, the rest of the questions are pretty personalized or about finances and the cost of treatments. So
Well, let me just add that. So if patients are concerned about the cost of PCOS or have personal questions, we're happy to set up a consultation with you and talk to you about those. Any patient that comes in to see us and talk about PCOS when we are developing a treatment plan, we'll send it over to our financial clearance folks, and they'll help you figure out what's covered by your insurance and what's not covered by your insurance so that you're not surprised. And then that usually can be very helpful with proceeding with treatments.
okay, so we want to just launch our last poll, which is, do you feel more educated about PCOS after watching this webinar? Just a few more seconds.
Okay. I'm missing the Jeopardy music here. Oftentimes when people do polls, sometimes there's a little music. And
Okay, I'm going to
There we go.
share. So you
Oh,
did
good.
good job. Good job. I want to thank you so much for attending this webinar and for sharing your responses with us. Thank you also to Dr. Puscheck for sharing this
Thank
information
you.
with us. Please check our website for dates of future webinars. If you have a question that we didn't get to, or if you think of something that you would like to ask after this has ended, please send it to the email of info, I-N-F-O, at inviafertility.com. Stay safe and healthy.
Thank you so much.